Today we'll just do neck, and I don't know, 2 weeks from now or so we'll do head, which is considerably more complex than that. This is probably an AP film, because probably the person's back was against the receptor, and the x-rays are coming from the front. This is an AP film of the neck. This is not very revealing of anything. I can sort of see that there must be vertebrae there of some sort or the other, but I can't hardly tell one from the other. In fact, the only thing I really see on this AP view of the neck is the spinous process of C7. You know, cervical vertebrae except for C7 have bifid. That means branching spinous processes, and C1 doesn't. C1 doesn't have a spinous process at all. But mainly what I see here is this radiolucency, which is what? No, vertebral canal is filled with a water density structure. Radiolucency. What's the most radiolucent thing on Earth? Air. That's what that is. That is the trachea here, and see narrow right there, and then gets wider above that. Well, this whole thing is not the trachea. This is the larynx and trachea. And that narrow zone right there is where your vocal folds are, which is the narrowest part of your airway. All right? So above this is, in fact, even from about here up, from about C6 up is larynx, really. And from C6 down is trachea. And that's about all I can see in this. You see a bit more in a lateral neck film. And I've labeled, these are the things we're going to be looking for. You don't expect to see everything. It depends upon the person. I'll explain that in a bit. Obviously, we expect to see the individual cervical vertebrae, the hyoid bone. Then we really don't expect to see, inferior to the hyoid bone, the thyroid or cricoid cartilages, because these are cartilage, and most cartilage is water-based. The cartilage is water density, and it shouldn't really distinguish itself from other regions. But what happens is, as you get older, a lot of this cartilage calcifies, and then you can see these cartilages. The thyroid cartilage has all these named structures that are labeled here, so I shouldn't have to repeat them. It is open in the back. I'll emphasize that. The thyroid is not a circular cartilage. It has these two laminae which do not meet at the back. So there's a complete gap there that leads to where the pharynx lies. The cricoid cartilage, on the other hand, is a complete circular cartilage, and it is said to be shaped like a signet ring, which is just, a ring that gets wider as you go from the bottom to the top. And this back part of it is called the lamina, and it is much taller than the front part, which is the anterior limit of the cricoid arch. The fact that the cricoid is circular means that if you put a tube, an endotracheal tube, down in a patient and keep it there for a long time, that's where you're going to get trouble. It's going to rub against the mucous lining of the cricoid, and it can scar and can lead to a narrowing of your passageway there. There's no possibility of that happening as it's passing through the zone of the thyroid cartilage, because that's not completely circular. All right, here is a picture with the right thyroid lamina, right half of the cricoid removed, just to show you really this here, which is called the arytenoid cartilage, which there's one on the left side, one on the right side. It articulates actually at a real joint, a real little synovial joint, on the upper surface at the junction of the arch and the lamina. This is the person's left arytenoid cartilage, and that's the thing to which the vocal fold attaches. You're going to do larynx later, all right? So you don't have to remember what I'm telling you now until later, all right? But the arytenoid is really important because that's where your vocal fold attaches, and it also is where the muscles that tighten and loosen your vocal fold and therefore modulate your voice attach. Then there's these bunch of little cartilage bunch. There's a couple of little cartilages on top of the arytenoid that no one cares about at all. So what can we see now that we know something about the structure of the larynx in this person who is old enough to have some calcified cartilages. We can see, and you can see this in everybody, whether they're calcified or whether they're old or young, is that you see the hyoid bone here, because that's a real bone. All right? And you see in this person what is clearly the lamina of the thyroid cartilage, or the two laminae superimposed on one another. Here is the superior horn of the thyroid lamina. Here's the inferior horn of the thyroid lamina. Again, the two are superimposed on one another, right and left. And I can make out what I think is a line right here, and sort of going across like that, and coming back up again, which is the cricoid in this person. You can also see the epiglottis. The epiglottis stands out in relief because it's got air on either side of it. So you can see that, even though it's a cartilage and probably is not calcified, but it does stand out because of the surrounding air. Still, this is not a lot, and so almost all studies nowadays of people with suspected neck injuries or neck pathology are CT scans. And this is a cross-section of the neck, and pretty much everything we're going to look at is labeled or is in this cross-section, except when you get a little bit higher in the common carotid divide. So this is below the division of the common carotid, which is around C3, C4. So I don't even know. The only thing I guess I want to point out is some of the relationships we're going to emphasize, all right? We're going to emphasize the fact that the common carotid artery, and then internal after the division, is always medial to the internal jugular vein. That's a fixed relationship. We're going to want to emphasize that in the carotid sheath, in the posterior part of the interval between the carotid artery and internal jugular vein, is the vagus nerve. Outside the carotid sheath, sitting on the fascia over your muscles here, which are called prevertebral muscles, you haven't looked at them yet, is the sympathetic trunk, and that is therefore posteromedial to the carotid artery. And outside the sheath and posterolateral to the vein is the phrenic nerve, and the phrenic nerve and the vein themselves sit on this muscle called the scalenus anterior that you know about. We have the trachea here, which has cartilaginous lateral anterior walls, but the trachea has a membranous posterior wall, which is thin. Posterior to the trachea is the esophagus, and in most people, it is usually posterior and slightly to the left of midline. And we'll see that in one of our CT scans, and another we'll see a CT scan of a person where it's almost perfectly posterior. Crossing the second through fourth tracheal rings is the isthmus of the thyroid gland, and then the lobes lie on either side of the trachea and are usually interposed between trachea and common carotid artery. In the groove between the trachea and the esophagus on either side is the recurrent laryngeal nerve. We'll see sternocleidomastoid, we'll see trapezius, but those are the important relationships, the ones I've just mentioned. So here's a CT scan starting at T1. Now, you say starting at T1, that's not the neck, that's the chest. But it isn't. I mentioned to you when we did the chest that the jugular notch of the sternum is opposite the T2, T3 disc. That means the neck goes down in the front, well below T1. So the neck is quite tall in the front, taller in the front than it is in the back. And the neck in the front goes down to the disc between T2 and T3. And we see things that are pretty obvious. We see that the most anterior muscle of this region, which is the sternocleidomastoid. We see that deep to the sternocleidomastoid are common carotid artery and laterally the internal jugular vein. The internal jugular vein is always deep to the sternocleidomastoid, its whole length in the neck. And, I mean, deep and in contact with it, its whole length in the neck. The artery being medial to the vein, you'll see it sometimes is fairly far removed, or the vein will be interposed between the artery and the sternocleidomastoid as you get higher, but at this level, the artery is actually sort of deep to sternocleidomastoid too. Radiolucent structure right here. The only radiolucent structure in the neck in the middle, at this level anyway, at this low down level, is the trachea, and you actually can see that it's got, you know, it's rounded anteriorly and laterally and sort of flattened posteriorly. That's where the non-cartilaginous part is. This thing which I've labeled esophagus is the esophagus, all right. It's got a little air in it. People swallow air all the time. But this is not only, the esophagus probably is a bigger thing than this. And it's just, this is the part which is collapsed and has no air in it. And you'll see that more obviously as we go up the neck. So we'll go here and we'll work our way up. Nothing very exciting has happened here. Nothing very exciting. I start to see something right there. All right, well, that's something which crosses anterior to the trachea is clearly the thyroid gland. So that tells us we must be at the 2nd through 4th tracheal rings. We see that the thyroid is here interposed between the common carotid artery and the trachea. So this is the isthmus, but these are the lobes of the thyroid gland. And we keep on going up. Nothing exciting. Still trachea with that flattened or even concave posterior wall. This is just labeling these things. This muscle, which has not previously been labeled, but it's always been there, posterior to the internal jugular vein, is the scalenus anterior muscle. And here is the esophagus. This whole thing here, even though there's no air in it, is the esophagus, both behind and to the left of this person's trachea. Now, do you have good imaginations? I do. As a result of which, that little white dot right there, I really don't know what that little white dot is, but I know what it ought to be. It ought to be the thing located in the lateral part of the interval between trachea and esophagus. Therefore, it ought to be the recurrent laryngeal nerve on the right side. Is it? I have no idea. That's not the point of this lecture. The point of this lecture is to tell you what ought to be there. That is what ought to be there. In the lateral part of the interval between trachea and esophagus is the recurrent laryngeal nerve. You see, that one looks clearer to me, that little gray thing. We know that in the posterior part of the interval between the common carotid artery and the internal jugular vein is the vagus nerve. So I actually believe that probably is the vagus nerve. Nerves really don't show up very well on CT by and large. So you can't expect to see this in everybody, but I picked one I thought you could. And there's here is something too, maybe. I don't care if that's it or not. I know that on the scalenus anterior, posterolateral to the internal jugular vein is the phrenic nerve. That's the point of this. That's what you should have in your mind. On the anterior surface of the scalenus anterior, posterolateral to the internal jugular vein is the phrenic nerve. So that's it, maybe. And we keep on going up. Nothing very interesting is happening. And now we change to a different person. And the different person was chosen because this is an older person whose cartilages are calcified. And you'll be able to see them well. Whereas if we had followed this, who is this? Do I give an age on this person? Yes. This is a 29-year-old woman. Her cartilages are not calcified. And as we went up the neck, we would have a hard time seeing the cricoid and a hard time seeing the thyroid. We'll come back to her later. But I switched to this older person where these things are not so hard to see. So I really shouldn't have to label this. Here's a common carotid, internal jugular on this side, common carotid, internal jugular on that side. Here's a sternocleidomastoid in contact with the internal jugular vein, sternocleidomastoid on this side, thyroid isthmus, thyroid lobes. Here maybe is our vagus nerve. All the other nerves are made up, so I didn't, This is our trachea, very clearly our trachea, because it has that flattened or even concave posterior wall. This person, the esophagus, is directly posterior to the trachea. It doesn't seem to be have any extension to the left of it at all, but that's not typical. Keep on going up. Why can I see in the trachea that white? Here's another one too. That's white, white, white. Why can I see that in the trachea? Well, say it loudly. Be bold. What?
Calcified cartilage?
Yes. She was right, and you were right too. You're all right. This is like Lake Wobegon. Everybody's above average. All right. Yes, you're absolutely right. The actual cartilages of the trachea have calcified partially in this person. So we'll see little zones of calcified tracheal cartilage. As we go up higher, nothing very interesting, nothing very interesting. See some air in the person's esophagus. Go up higher. We're already superior to the isthmus of the thyroid now, but we're still at trachea. You can tell by that back wall, which is concave. Go up higher, higher, zap. The back wall of the trachea is not concave anymore. That's because this is not the trachea anymore. When that back wall becomes rounded, you have reached the cricoid cartilage. And this person's cricoid cartilage is partially calcified, so we can see it. And then I changed the name of the esophagus to the pharynx, because in fact, the boundary between the pharynx and the esophagus is the lower edge of the cricoid cartilage. So in reality, if you can see the cricoid, you're at pharynx. And if pharynx will be anything above that, if you're below cricoid, you're at the level of the trachea, you'll be looking at esophagus. Keep on going up. See a lovely cricoid. Now we start to see here a calcified zone of cartilage in this person that actually articulates, forms a joint with the posterolateral part of the cricoid. And that is the inferior horn of the thyroid, which has a genuine articular surface joint with the cricoid cartilage, and the thyroid rotates on the cricoid. You'll learn that when you study larynx. As I keep on coming up, we see more of the inferior horn of the thyroid cartilage. We are now, by the way, so high that the arch of the cricoid has disappeared from view. You remember, the arch is not as tall as the lamina at back. So as you keep on coming up, you're going to get the whole cricoid, then its arch will disappear, but you'll continue to get the lamina, which is taller than the arch is. So we're seeing now just the lamina of the cricoid, essentially. And now, here was our inferior horn of the thyroid cartilage. Now we've actually reached the lamina of the thyroid cartilage on both sides, quite calcified and very easily seen here. Keep on going up. Nice. Both laminae of the thyroid cartilage. Keep on going up. We're just about at the top of the lamina of the cricoid, which is going to disappear soon. And I thought it disappeared here. And I thought this thing right there was the arytenoid cartilage. I still think that's the arytenoid cartilage, the sort of whitish thing there with a black center. And one of the reasons I thought it was, I must tell you, is because these are the vocal folds. Now, how do I know those are the vocal folds? When you look at your airway, it's rounded and anteriorly, and then it starts to turn to a V. And the minute you get to that V, the anterior V of the airway, those are the vocal folds. So if these are the vocal folds, I know the vocal folds are attached to the arytenoids, so these must be the arytenoids. Keep on going higher. These are still vocal folds. This is more obviously a separate thing than the cricoid cartilage, so it's more obviously a arytenoid. Keep on going higher. We're above the vocal folds. You see how the V is gone? Now we're back to a part of what's called the supraglottic part of the larynx. The space between the vocal folds is called the glottis. Or the vocal folds and the space between them is called the glottis. So this is the supraglottic part of the airway. And we keep on going up, and nothing very interesting happens. We're at the level of the thyroid notch here. Thyroid cartilage hasn't disappeared, but it's notched in front, if you remember our drawing of it. So that's what we're at the level of the thyroid notch. And then we'll start to see the superior horns of the thyroid cartilage continuing superiorly beyond the level of the laminae, and they will eventually disappear. This one's disappeared on the left side already. The right side is a little higher, or the CT scan might be a little oblique. Yep, well, I didn't carry it any higher. We'll see it I didn't carry it any higher for that. You've dissected the neck. You've memorized the names of veins in the neck. The veins of the neck are like the branches of the lumbar nervous plexus. The lumbar nerve plexus is the most variable nerve plexus in the body. You go in and you look at a person, you don't know if they're going to have all the nerves or just some of them, but you have memorized a set of relationships. If a nerve follows that relationship, you give it that name. That's it. The veins of the neck are similar. People are missing veins. They have more than they should. You can even be missing your external jugular vein. So, again, you just rely on relationships as to what you're going to call something. I know that the vein which runs down along or parallel to the anterior edge of the sternocleidomastoid mastoid, so it's called a communicating vein. So if I see something up against the anterior edge of the sternocleidomastoid mastoid, that's what I call it. I know a vein that runs just parasagittally down near the midline is an anterior jugular vein. Well, this person's got a communicating vein on the right side and a communicating vein bigger on the left side. Has a left anterior jugular, no right anterior jugular. That's not a problem. This muscle that's appearing in the back is the trapezius, and this little thin slip of a muscle you can see right here, which is most anterior soft tissue structure in the neck, or other than fat, is the platysmal muscle, right there. And in this case, it's anterior to the communicating vein, as it will always be. All right. So we keep on going up. This is trachea. You can tell by the back wall being concave. Back wall concave, trachea. This is the young woman again. This is the 29-year-old woman. You may not consider a 29-year-old woman to be a young woman, but I consider a 29-year-old woman to be virtually a baby. When my own daughters are over 40. All right, you might hear about that. So this is the 29-year-old woman. The wall is no longer concave or indented or flat. We are therefore at the level of the cricoid. I don't see the cricoid. She doesn't have a calcified cricoid. She's a young woman. But I know when that wall becomes curved and is no longer flat or indented, it is the cricoid, which made me change the name of that from esophagus to pharynx. Keep on going up. Even nicer cricoid area. She must have calcified, these must be, I don't know what the hell they are. Let me go. Yeah, there's nothing these could be other than inferior horns of the thyroid cartilage. I mean, you can almost see a thyroid cartilage here, right there. These must be her inferior horns and back wall of the lamina. They seem awfully radio-opaque, I must say, but I can't think of anything else they could be. So she may have some calcification in her thyroid cartilage. Keep on going up. Here are the vocal folds. There's a little calcified dot there, which might be in her arytenoid of that side. When you see that V there, that's always vocal folds. But nothing else has changed. You still have a common carotid. You have an internal jugular lateral to it and in contact with the sternocleidomastoid. Going up, up. We are now in the supraglottic portion of the larynx. I have no idea what that is. Yeah, when you give these lectures, sometimes you see, I can't even begin to imagine what that could be. Must be a calcified something. I mean, maybe it's a very, you know what, I can't imagine it. I can imagine what it is. I know what it is. Huh?
Any contrast?
There's contrast in the vasculature. Absolutely. This person's had intravascular contrast. I'm glad you mentioned that. Otherwise, the vessels wouldn't come out nearly this nice. They would be the same ugly gray that all the muscles are if you didn't have intravascular contrast. I have an idea what that is. You have an idea too?
Could it be calcified retinol?
No, I think you're right. You want to come out and finish this lecture? The arytenoid cartilage. Look at the arytenoids. They have this sort of peak there. They have this part which extends forward, which attaches the vocal fold, a part which extends backwards and laterally, which attaches to muscles, and then this thing which just rises high, like a peak. And I'll bet you that that's what we're looking at, a calcified peak of the arytenoid cartilage. Never thought about it, but I could not even begin to think of anything else it could be, to be honest with you. All right. Keep on going higher. Platysma hasn't changed. Here's our communicating vein. I don't know why this is not labeled, but the vein on the lateral surface of sternocleidomastoid on both sides must be the external jugular vein. What other veins on the lateral surface of sternocleidomastoid? Nothing. These must be the superior on this side, superior horn of thyroid cartilage calcified. On that side, superior horn of thyroid cartilage slightly calcified. Keep on going up. And now we start to see, which lies underneath the mandible in the digastric triangle, what is the submandibular gland. And we start to see the body of the hyoid bone anteriorly. And the hyoid bone is a U-shaped structure, has greater wings extending backwards from that. Hers are not fully fused with her body, but we see the greater wings of the hyoid bone continuing posteriorly. This is actually the epiglottis right here, and these are called the valleculae, but you don't know about that yet. Submandibular gland still is in view in the digastric triangle, which we can't see, but we just know that's where it would be. Keep on going up, up, up. Oh, I know, I switched back down again because I wanted to show you the vertebral artery. You can't see where it's coming from. The only way you could identify this as vertebral is to realize the person's had contrast. It's a big artery, but if we follow it up, that will be the clue. Let's just follow this thing. Up. Doesn't enter the vertebral foramen of C7, but does enter the vertebral foramen of C6. So the vessel that comes up from below and enters the vertebral foramen at the level of C6 is the vertebral artery. And we see on the person's right side it's bigger than on the person's left side. You know that that's not uncommon at all to have unequal vertebral arteries. And here I've labeled the external jugular vein as the vein on the lateral surface of the sternocleidomastoid. We keep on going up. This is what I wanted to emphasize. When I get here, I'm at C5, C6. I look at my common carotids. This is low. That's fine, common carotid fine, internal jugular vein, but doesn't this common carotid look odd? And the reason it looks odd is because we cut it right at its point of bifurcation. This is pretty low for a bifurcation of a common carotid. It's usually up around C3, 4, but these things can do whatever they want. And actually, you won't appreciate this. All right. If you read core now in front of the things on surface anatomy, there's now a little disclaimer which says there is so much variation in here you should not rely on these or believe they're chiseled in stone. That's because I went and did a study of this variation just from my own personal education and found that it's unbelievable how much variation there is in these things. So I tell you a common carotid bifurcates at C3, C4 because in my own, I have to have something in my mind, but it can be C5, 6, it can be anywhere. These things can do whatever they want. All this surface anatomy that I had spent a long time memorizing myself is probably of no clinical relevance at all. Before CTs, it was important. Now you do a CT and you see where this person's vessel actually does divide. You don't have to guess where it might divide. All right. So here's the branch. But what it does is true is when that divides, it is always the case that the external carotid comes off the anterior surface of the common. And the continuation of the common is posterior to the external carotid, and that is the internal carotid artery. Here's our vertebral going through the C5 vein. So if we follow that external carotid artery, it will stay anterior to the internal carotid until it gets high enough, and then it will jog over to the outside, towards the lateral side, and then turn back up again. It's not called external because it's external. It's called external because all its branches supply external structures, and the internal carotid is called internal because it supplies the brain, which is an internal structure. So we're going to follow this internal carotid artery, and maybe I'll just focus on that. It's external. We'll just look at it. Still anterior. Looks like it's a little anteromedial. That's irrelevant. But now it's making its jog to the outside, right there. And then it's going to turn up and run behind the ramus of the mandible in the parotid gland. They haven't dissected that because I haven't dissected the parotid region, but that's what the external carotid artery does. Comes off from the front surface, runs up a little bit, turns laterally, reaches the area behind the ramus of the mandible, and turns up again, and runs in the parotid gland. There's another, this is the parotid gland. You've seen it even though you haven't dissected it. That little mucky stuff there is the parotid gland. Also running in the parotid gland, lateral to the external carotid artery, is the retromandibular vein. If we follow this retromandibular vein back down the neck, it's what's going to give rise to our external jugular. This is still parotid gland here, retromandibular, and now it's on the surface of the sternocleidomastoid, having become the external jugular. The internal carotid and the internal jugular, there is a slight change in relationship, a detail that I would hope Dr. Larson doesn't ask you about, and that is generally when you're right at the root of the neck, way down low, the internal jugular is slightly anterolateral to the carotid artery. Then in the middle of the neck, it is dead lateral to the carotid artery, and then as you get into the up region of the neck, the vein is slightly posterolateral to the carotid artery. And now we're seeing the vein is posterolateral to the carotid when we're this high in the neck. And nothing else has changed. So we can just follow these. If we follow our internal carotid and our jugular vein, we get to the point. We'll worry about this later. We'll get to the point where they enter the skull. Here's the jugular vein. You haven't seen that because you haven't done the inside of your skull yet. And here's the carotid artery entering the skull through what's called the carotid foramen. This is the mastoid process of the skull. And I don't want to bother with the styloid since you probably don't know what that is yet. All right. Now, that is the basic thing. That's it. That's it for the neck. Just a few little interesting things, then we'll call it quits. I have labeled, in this other person, an 18-year-old woman, cervical vertebrae. Here is IJV. We are at the split of the external and internal carotid, or above the split of the external and internal carotid. Here on this side, there's the split, although this is not directly anterior to that. It's still sufficiently anterior that we know it's external carotid. The question I'm asking you is, what are all these other things that we didn't see in any previous section? A big glob there, a big glob there, a big glob there, a big glob there, there. What do you think those could be? This person came in tired, very tired, having just kissed her boyfriend. Yes. These are all enlarged cervical lymph nodes. We never see them in dissection. Never see them in dissection. But they surround, they're all around the internal jugular vein, outside the carotid sheath. And they are the deep cervical lymph nodes, which Dr. Larson you did lecture on lymphatics already, so you know that they exist. All these nodes in the vicinity of the internal jugular vein, and this person has very enlarged deep cervical nodes from currently having mono. Well, this is for the people who are way up to date on their embryology. How many of you are? I don't even expect an answer from that. All right. This is a 3-year-old female with the most common embryological anomaly of the neck. All right, the one you're, and this is called a thyroglossal duct cyst. Now you do know, I'll bet you, that, or should know, that the thyroid gland arises from a diverticum in the tongue and drops down. The reason I think you should know that is because some of you have pyramidal lobes, I'm sure, in your cadaverous thyroid gland, and some of you may have actually been able to trace a ligamentous structure from the isthmus up higher in the neck. You didn't follow it to the tongue where it would have gone, or would have gone to the hyoid bone and been interrupted by the hyoid. But the thyroid starts in the tongue region and migrates down your neck. And sometimes little bits of it get stuck or separated off from the main bit and get stuck in its descent and become cystic, which means get filled with fluid, and that's what that is, the most common anomaly of the head and neck in development is a thyroglossal duct cyst. This is an MRI. I don't think there's a reason to go through this MRI, really, just to show you what an MRI of the neck looks like. It's gorgeous, but aside from that, there's no particular reason to go through it. And also to show you that, and there's no way, I mean, you know, without going up and down through the sections, you would know what these things are. But the submandibular gland, which looked like just a regular gray thing in CT, actually has a different MR picture. It is more distinct as a structure. And so if you really want to look at these glands, it's much better to look at them in magnetic resonance. Here's the parotid gland. Again, it was just gray mass in CT, but now we actually see something here. There it is there, which is really looks different from all the muscles and everything around it, and is very clearly a glandular structure. This here is must be the retromandibular vein, and that there must be the external carotid artery medial to it, because that's always the way it is. And this other one on the right doesn't look like anything. Now, here's a person who's had a CT angiogram of his neck because he's been shot with a gun. And they wanted to see whether the vessels of his neck were injured. They were not. But I'll just show you. Now, this is volume rendering. Remember where you take all of these CT images, you colorize them, and you make them appear three-dimensional. And I just show these things because they're just super, super pretty. And we're going from front to back in sections. We're coming out the back of his skull. And now we're coming forward again. Now, what can you really see in this? All right, we can see here's the common carotid coming up. Here's the superior thyroid coming down on that side, probably superior thyroid here on this side. We'll see it better in lateral view. We see the bifurcation. We know that the anterior one is the external carotid, the posterior one is the internal carotid. Otherwise, and we see beautiful vertebrae, we see gorgeous vertebrae. And we see an artery coming up here through the intervertebral foramina. Through the transverse foramina right there on this person's left side, right here on this person's right side, and those are the vertebrals. And if we continue, see how lovely the vertebrals stand out now through the transverse foramina. You can still see them beautifully. Boy, you can see the anterior arch of the atlas here, right there. Even you can see the anterior tubercle of the atlas. Expect to see the dens behind it, and will. If we go backwards, are we going backwards? Yeah. Ugly dens. I mean, it's this thing here. It didn't come out as pretty as the rest of it. In lateral view, here's the movie starting from this patient's left and sweeping to the right. Some of the things we can see without even doing anything is that here's the body of the hyoid bone right there. You see where I'm pointing with this little hand. Here's the left greater cornu of the hyoid. Here is the atlas here. Here's the axis there. We see this is the external carotid artery right there with all of its branches. Here's the internal carotid with no branches right here. It's hard to see because things are so overlapped, but we'll deal with that in a second. Some things we can see here is an artery running right along the inferior surface of the occipital bone, which in fact is the occipital artery from this person's left occipital artery. We can see an artery here which is crossing the mandible. That's the person's left facial artery. But let's take a look at this going from left to right. Coming back again, it's the person's right carotid axis, left carotid axis. Because of the overlaps of the carotids, you really can't see things that well. So let's go back to where we're just looking at the person's left. Here, we're all the way, I'm sorry, person's right. We're all the way to the right of this individual, to the individual's right side. And I'm going to come slightly to the left until we see the carotid vessels. And we can see some interesting things here. Here's, first of all, this is the region of the carotid sinus. You can see the dilatation quite clearly in the internal. Here's the external carotid there. This vessel coming down, what's that? Right, superior thyroid. First branch, anteriorly directed branch of the external carotid. We come up, we see a branch coming forward, and let's look at this branch, which is the second anterior branch of the external carotid, because this is a little anomaly, a little variation. I'm going.
Everything is there, the lingual's there.
Yes, that's right. This first branch right there, we see coming up on the inside of the mandible. This branch, which is here, if we go back, we'll see ran on the outside of the mandible. So I'm going to go a little bit back to the right. This is going to be the facial artery. It runs external to the mandible. As we come back to this person's left, here it is again. This is the facial artery right here. Then it's hidden from view because it's running on the external surface of the mandible. And then we keep on coming to the person's left, and we see the origin of that facial artery, and we see the origin. It shares in common with this vessel, which is what? Lingual. So, this is a person who has a common linguofacial trunk, a very, very common variation in the external carotid. You all hope that the lingual comes off separately and then the facial comes off after that, but in many people, they come off a common trunk, and this person has a common linguofacial trunk. So here is our superior thyroid. Here's our common linguofacial trunk. Here is the lingual, which is traveling up towards the tongue, deep to the mandible. Here's the facial, which is traveling up, and then will pass external or lateral to the mandible. Here's the continuation of the external carotid, heading up right there. And this branch, which right there is, in fact, the occipital. And if we go backwards to the right, can we see where it's going? Yeah. Here's the occipital right here. Here it's coming off right there from the back. So we can see quite a few of the branches. You're not. Will you ever see a posterior auricular? The answer is no, because I don't believe they exist. I mean, every book has them. Probably the one. I probably have it too. I can't say I've ever seen a posterior auricular. I'm an old man who looked at a lot of bodies. All right. Because things are so hard to see, overlapping right and left, you can just get rid of all the bones. And that's what's done here. This is the pure CT angiogram with all the bones subtracted out. Here's with all the bones in place. So here is our famous right common carotid, the one we looked at carefully, coming up, dividing into external and internal. Here's the superior thyroid on the right side. Here's our common linguofacial trunk on the right side. Here was the lingual branch on the right side and the beginning of the facial branch on the right side. And here was the occipital branch on the right side. Let's look at the left side. Another anomaly. Here's the left common carotid coming off, a double anomaly. Left common carotid coming off, bifurcating into external right here and internal right there. And look at this. Anyone want to say what they think this is?
Superior thyroid.
Yeah, part of it's superior thyroid. Certainly this part, which is looping back down again, because the superior thyroid always has to loop down to get to the thyroid gland, is the superior thyroid. But in this case, this part which is continuing up, and you could have, with great effort, seen it on the film. And I put the film online for you so you can look. That's the lingual on this side. So this person has a double anomaly. Has a common superior thyroid lingual trunk, and we were terribly excited last year because there was a body with one, because people otherwise don't believe me. And this person also has this common trunk arising from the common carotid artery, and not from the external carotid artery. This reinforces my early statement is these things can do whatever they want, all right? Now, there's a majority. You learn the way things are in most people, but you can never be surprised when things are slightly different. We now continue up our external carotid, and all we see is the facial coming off anteriorly and an occipital coming off posteriorly. And then we trace it up to its termination, which you won't see until you do the dissection of the parotid region.